Good morning, good evening, also good afternoon. Welcome to this next series. This will be the 45th webinar, and this is now the SIG this month is autism. And we will be starting off with talking about autism mimics, learning through cases. I'll give a brief introduction, followed by autism mimics and enigma, and by Dr. Tuba and from Boston, and then Dr. Hilal from Bangladesh will talk about autism mimics from perspective of a child psychiatrist. Our experts today are Professor Veena Kalra. Uh, yeah, I can just talk about the speakers. Can you please show the slides, please? Yeah, so Dr. Tuba Rashid Khan, she's a pediatric neurologist at prestigious Autism Spectrum Center, Boston Children's Hospital, and she's done her MPH and EDM, and she's a recipient of Futures in Neurology Research Award by the American Academy of Neurology and the esteemed E.B. Baker Teacher Recognition Award, and recognition as the Pelletry Advocate by the AN. Author of the inspiring children's book, My Friend Adam. Then we also have Dr. Hilal Uddin Ahmed, who will be talking from as a child psychiatrist from the psychiatrist point of view, how to look at the autism mimics. And he's an associate professor and head department of child, adolescent, and family psychiatry unit, National Institute of Mental Health, Dhaka, Bangladesh. And he's president of the Bangladesh Association of Child and Adolescent Mental Health. And he has done a Queka Fellow in Child Psychiatry from South Korea, and he has 60 publications, and he's got the Professor Hiadul Islam Gold Medal for contribution in psychiatry. Then, as usual, besides our esteemed speakers, we have experts from different resource settings. So we have Professor Veena Kalra, who was my mentor, and she has been my mentor, and she was probably professor and head of Department of Pediatrics at AIMS, and the founder president of Association of Child Neurology India, and the former, you know, uh, he was a national delegate and then former president for the Asian Oceanian Child Neurology Association and chairperson of the Educational Committee of ICNA. She has received innumerable awards, including three honorable President of India awards and recipients of lots and lots of medals and lot of global awards. And she is currently working, has been a pioneer for pediatric neurology, and under her leadership we had co-founded the pediatric neurology DM pediatric neurology program in South Asia first time in 2004, and we have now completed 20 years. And yeah, next is our very dear friend, Dr. Biju Hamid, who's consultant in pediatric neurology and neurodisability and movement disorder at the Great Ormond Street Hospital of London. And he's currently as head of pediatric neurosciences in Mubadala Health in UAE, and also heading another such center he's establishing in Abu Dhabi. And he is basically, his name is synonymous with ICNA because from time immemorial he has been associated in the core group of ICNA. Currently he's chair of the education committee ICNA, International Child Neurology Association, and the co-program director of the International Child Neurology Teaching Network. He's done PhD in neurosciences from University of Bristol and traumatic brain injuries. Dr. Lokesh Lingappa, a dear friend and very well-renowned pediatric neurologist from India, and he has had his training from UK and initially DM adult neurology in NIMHANS, and he was awarded the best outgoing neurology student in NIMHANS, and also received the travel fellowship grant to Montreal, Canada. He has been really working and was very experienced pediatric neurologist, and currently he's president-elect of the AOCN, whose current president I am. So he's the president-elect. And besides that, now we will be having a moderator. Moderator is Dr. Lokesh Saini, who has been our alumnus, and currently he's in charge of pediatric neurology at All India Institute of Medical Sciences, AIMS, Jodhpur. He's done his DM pediatric neurology for the HUS, and he's interested in neuro rehab and neurodevelopmental disorders, and has more than 185 publications, and got the Neuro Rehab Initiative of the Year award by the Indian Academy of Neurology, and got two international scholarships for the American Academy of Neurology. So before we proceed further, because this is the beginning of the Autism SIG, I hope Professor Kalra is there. Professor Kalra joined? She hasn't joined. So
Uh,
whenever she joins, we'll
mm,
ask. Huh? She hasn't joined. And we
no,
also have our dear, sorry, Asmita. Has she joined?
no, ma'am, she has not. No, no.
Okay, whenever she joined, we'll let her speak. And I think I also want to welcome Dr. Hassan Tegul, who is a dear friend from Turkey, who's been heading the Turkish Neurology Association there and has been really actively participating in many activities of the AOCN. And I hand it back over to I think Prashant.
Yes, ma'am. Let me take it over from here. So, today's agenda is quite packed, and we'll start with just a brief introduction by none other than Dr. Shefali Gulati. So, Asmita, can we have the CV slide here? So, we all know Dr. Shefali as our current president of AOC, and she is the uh, national delegate for SMA. She is the program director for the DM Pediatric Neurology course, which was the first, and she was also the co-founder along with Professor Veena Kalra. She is the lead faculty for the Center of Excellence in Advanced Research for Childhood Behavioral Disorders at AIMS New Delhi, and as well as an adjunct faculty for the National Brain Research Institute. She has a lot of interest areas, and autism is the prime area where Dr. Shifali has a lot of her work. She is president to various other associations. She is the current chairperson of the AOPN Delhi. She is a co-convener of multiple pediatric specialty subsections. She is the editor of the Autism Journal, which is a SAGE journal, and she has innumerable awards to her name. The recent ones is from the AN in 2024 and the General Physician Association of India. Uh, Dr. Shifali ma'am has almost more than 400 publications, a lot of them in major reputed journals that we have. And let us hear from Dr. Shifali ma'am. Yes, over to you, ma'am, for the introduction of the talk.
Thank you, Prashant. And I think Professor Kalra ma'am have joined. Ma'am, can you say a few words? I had requested for you to say a
Yeah,
few
I
words,
will.
telling that you are my
Certainly.
mentor. You're my
Yeah.
mentor, and under your
Thank
leadership, we had
you.
started the DM Pediatric Neurology program
Thank,
exactly 20 years back. Yeah,
yeah,
please.
thank you,
Yeah.
Shifadi. Thanks a lot. And it's a great honor and privilege to be with all of you, world leaders in this area, to talk about a problem that's really a burning challenge for the children of today. It's something that taken us by storm. It's something that we have not understood well. We are far from understanding. And it's something that sort of creates a lot of dilemmas in diagnosis, much as we may think that the child looks autistic, but there are so many autism mimics that confuse the best clinician, the best families, and the whole clinical paradigm. What's very important is that we are sitting right next to the World Autism Awareness Day. We are right next to 2nd April. So there couldn't be a better time than to talk about autism as of today. The other important thing I really appreciate is that it's important to get information as to how autism is diagnosed, perceived, recognized, and the cause identified, therapies given in different parts of the globe, and how people have got challenges in the diagnosis and how they have tackled. So I think these kind of deliberations are really important to help to unify our thinking across continental barriers and across different cultural ethos to be able to understand this enigmatic disease and entity well. And I appreciate the organizers for organizing this so close to the Autism Awareness Day that it would be really a great contribution for this disease and for the families and for the medical profession. And I welcome you all, such leading experts, for this contribution. Thank you, Shifari. So we'll go on to
Thank you.
hear.
Thank you, ma'am. And with the 44th session we had last time, the number of attendees from countries have increased to 48. So I think that is very
Wow,
nice. And we
that's
have
very good.
presenters from various other countries today from
Very
Turkey
nice.
also. So I think that's very good. Yeah. Thank you so much. Uh, can I allow me to share the screen?
Please.
Okay. Thank you. So I'll just give a brief introduction before Dr. Tuba from Boston Children's is going to take over and talk in detail, and then Dr. Hilal will talk about from a psychiatrist perspective. So I just thought that I'll just give it starting, introduction that we all know that autism spectrum disorder is characterized by deficits in social interaction and communication, and they have some restricted repetitive patterns of behaviors and interest, and there are various other conditions which closely mimic autism. There is a high chance of misdiagnosis and delayed diagnosis, both of them, because there are a lot of overlapping conditions. But before going further, we need to understand that there is a recent increase in number of cases, which was like 1 in 157 in the year 2004 to 1 in 36, which is 24th March 2023 data. And in the England study, which we had done in 2011, we found 1 in 89 in the children age group of 2 to 9 years. It is seen 4.5 times in commoner than boys than girls, but now the ratios is coming around 3.5 is to 1. So now just giving you an overview, you may have, which are the masqueraders? You may have some sensory deficits in the form of hearing impairment. You may have neurodevelopmental disorders like intellectual disability, ADHD, social pragmatic communication disorders, developmental language disorders, autoimmune encephalitis, encephalopathies. And then you may have various psychiatric disorders like childhood onset schizophrenia, social anxiety disorders, post institutional autism syndrome, reactive attachment disorders, and depression and emotional neglect. So, this will be covered by the main two speakers after this. So, now there is a confusion when we say in our outpatient whether there is autism or no autism. What do you think in this? Whether it's the cat or a tiger? So we don't know whether it's an autism or not. So there's a tiger with the cat face, and then you have a you know and you have a cat with a tiger's face. So we are so confused most of the time. So we need to understand that what appears may not be so. So you have to delve little into it. And I think Dr. Tuba and Dr. Hilal will tell you through it. And basically, most commonly, what we see is LKS, Landau-Kleffner syndrome, or electrical status epilepticus in sleep. Both of them would have some language regression and seizures. But yes, in LKS, the language regression is after 3 years, and there is loss of receptive language. And EEG, you have sleep potentiation with bitemporal or centrotemporal discharges. In autism, you have generally a regression between 18 to 24 months, so it's less than 3 years, may or may not have seizures, and they are isolated subclinical EEG abnormalities called SEGA, which are there. And you have more demands involved, and you may have adherence to sameness, stereotypies, and repetitive behavior more with autism. Coming to ADHD, hyperactivity, sensory issues, difficulty in impulse control, and inhibition difficulty can confuse the case. In ADHD, they may not have strict adherence to routine, they have some attention issues. Cognition is usually better than in ASD alone. You may have social communication issues more predominant in autism, and adherence to sameness, stereotypies, and repetitive behavior in autism. You may have anxiety and avoidance of behavior. You may confuse autism with social anxiety disorder, but social anxiety disorder may have situational anxiety that improves with time and usually associated with physical symptoms like palpitation, sweating, and flushing, but normal development and cognition. You suspect autism if you have anxiety associated with social communication issues and adherence to sameness, austerity, and repetitive behaviors. Schizophrenia with Dr. Hilal will talk about in detail, which he sees more commonly than we do. But the social communication issues and restrictive language, you suspect schizophrenia where you have strong delusion and hallucinations of a new onset, usually more than a month, and a background of a normal development. With autism, you may have stereotyped speech, you may have global delay or isolated language delay or socio-cognitive delay. Psychosocial deprivation, you may have, along with autism, the common points would be abnormalities in social approach, difficulties in adjusting behavior to suit the social context, and difficulties in peer relationships. But the suspected psychosocial deprivation is more, if you have decreasing severity of symptoms over time, background of children raised in institutions, those who are emotionally deprived during their initial days of development are prone to it. So, CASI autism or post-institutional autistic syndrome. But when you have progressive worsening of symptoms, or if not intervention is not carried out, or and you have specific adherence to sameness, stereotypies, and repetitive behavior, points more towards autism. Then you have about this social pragmatic communication disorder. Both of will have difficulties in social communication. You suspect more of social pragmatic communication disorder if you have no, they don't have repetitive and restrictive behaviors. You may, and imitation and play activity is not affected. And the core symptoms of autism of restricted repetitive behaviors and fixed patterns of interest and stereotypies go more towards autism. Hearing impairment and autism both will have language delay, but in hearing impairment, the child likes the social contact, enjoys being touched and having hugs, has a good eye contact, it communicates with pointing or with hand gestures, and can often accept a change. There is no hyperactivity, aggression, or irritability. Whereas in autism, the language delay is accompanied by core autistic features. ID becomes a difficult situation, when you have communication difficulties and poor understanding. In ID, you can suspect when you have deficits across more functional domains. Skill development is slow, but even if it's all smears, and verbal or non-verbal modes of social communication may be observed, but the content will be limited. Suspect autism in the situation you have deficits in narrowly defined core areas of autism with deficits in social adaptive functioning. Skill development is uneven, faces major issues in language, communication, social emotional development. There's a criteria E in the DSM-5, which requires that disturbances are not better explained by intellectual disability or global developmental delay. That is something which we have to keep importantly. That is something which becomes very important. And also understand that ASD complicates the cognitive testing in this group, potentially leading to lower scores. Then one thing more before I hand over to my the main speakers, that why are these autism mimics there? ASD is often associated with other neurological comorbidities like epilepsy and intellectual disability. And we recently analyzed the data of 1,874 patients of autism, and we found 80% had comorbidities. And the commonest comorbidity was ADHD. So because of significant overlap between this, there may be some misdiagnosis, and there is a possible shared etiology between ASD and other neurological diseases. So they may be the combined, some genetic and environmental contributions may be there towards the etiology for all the things. ASD has 1,007 risk genes as per the Safari gene database. And you just see that, the ASD genes and the genes for epilepsy and ID, there is an overlap. And that is why there may be an overlap in their resistance. So what should we look out for? They may be overlapping features of autism with various other neurodevelopmental disorders and psychiatric illnesses. You focus on the core diagnostic criteria to confirm any psychiatric illness is present. EEG, especially sleep EEG, may be indicated at times of atypical regression, and keep an eye on the treatable conditions. Yes, as Dr. Kalra very rightly said, yesterday was the World Autism Awareness Day, and this whole month is the Autism Awareness Month. That is why we strategically took this month for the SIG for autism. And yes, the theme this year is colors. So we are celebrating the diverse spectrum of abilities in these children. And this is the institute where I belong, and this was the Institute on Autism Awareness Day in 2017. So I would now request Dr. Lokesh to take over the moderation and Dr. Tuba to start her deliberations.
So I invite Dr. Tuba to start with her talk.
Hi guys, can you see my slides?
Yes.
Perfect.
Okay,
But they're
great.
full screen. It's not full screen. It's not full screen as yet, Tuba.
I put it in power. Do you see it now?
It's the second slide which it has come, but not full screen as yet.
Not
they are
full
not-
screen,
Asmita, can
ma'am.
you guide?
Yeah, ma'am. Ma'am, I'll stop your sharing now.
Yeah,
Reopen
maybe
your
it's better.
PowerPoint. Yeah, reopen your PowerPoint.
Okay, do you see it now?
Yeah.
Is it full now?
No, still not
Not-
full screen.
Okay.
You can save this
I think we
presentation
can
on your
proceed.
PC.
We can proceed. Okay.
Yeah, if it doesn't work a third time, I may ask you to share it then. Let's see.
First, save your presentation on PC, ma'am, on your device.
I did. But It may be the low bandwidth. Okay, let's try a third time. And then if it doesn't work, I'll have you share my screens, my slides.
Low bandwidth.
Yeah, I think it's because of the low bandwidth. Do you want to try sharing my screen with my slides?
Ma'am, you can mail me the slides.
I did. I did it to Dr.
Asmita, I'm forwarding you.
You can start.
You can start without the full screen. That's okay. I think that's fine. It's
Yes.
okay. Meanwhile, she will start. I am forwarding to Asmita. You can start with the presentation. Dr. Tuba, with your slides. Can you start sharing again? Yeah. And the
Yeah.
moment Asmita starts. Yeah. Or actually, I'll share. Once again, I already have. Let me share. You give me the rights. Give me the rights back. I have her slides. Yeah. I'll just do it. Yeah. Once.
Yeah.
Yeah.
Sorry, this is a technical issue.
No.
Living
No.
continents away, but I can control my internet bandwidth. Okay, well, guys, let's start.
Yeah.
Thank you so much
I'm
for
just.
having me. And for those of you that recently celebrated Holi and Easter, happy Holi and Easter. And those of you observing Ramadan, happy Ramadan. And as you all very well commented on, it is Autism Awareness Month. And by some organizations, it is also known as Autism Acceptance Month. And this is a topic very dear and near to my heart.
Juba, is it okay? Your slides are okay? Full screen?
Yeah. Can you all hear me?
Yeah.
Yes.
Okay. So as I was saying, this is a topic very near and dear to my heart. And interestingly, autism awareness was started in the 1970s. And it was started as a week and now progressed to a month. So I have 20 minutes that was given for my talk, and I'll divide it into 3 parts. I'll be first talking about examples, then the differential diagnoses, and then important learning key points. So we can move on to the next slide. Are you able to move to the next slide? Okay, perfect. So in protection and compliance with HIPAA, I love flowers. So I have given my patients anonymous names named after flowers. These are cases that I saw, and often I'm sought off for second opinions, third opinions. And so I saw this patient a year ago. This is a 19-year-old girl. She presented with her very lovely parents, and she had been previously diagnosed with a mitochondrial disorder. They were presenting to me because for 3 years she was having escalating aggression. The interesting thing is, the humbling part of neurology is everything is generally likely versus less likely, right? And there's always the few patients where they don't meet the typical presentation. So typically with mitochondrial disorders, you're going to have those phases of regression. There's going to be liver involvement, eye involvement, heart involvement. And her opto exam was perfect. Her liver function tests were normal. And they didn't have any results that were genetically proven or any mitochondrial testing that proved this. The other thing is, in clinic, she had unsustained eye contact. She was minimally verbal, and she seemed calm in clinic, but after a while got very agitated. And so we did her psychological testing, and we were suspicious of Kleefstra syndrome, which, as you know, is highly associated with autism. And those kids, they'll have microcephaly, they'll have intellectual disability, hypotonia. And yeah, when we got the chromosome microarray, it showed the chromosome 9 mutation, and she met the criteria for Kleefstra syndrome. We did her IQ testing, which showed nonverbal IQ scores of 38 and a verbal IQ of 19. So she met the criteria for intellectual disability. She also met all the criteria for autism spectrum disorder. So how did this change the life of this family? Number one, this is their exact words from the mother. She had read all about mitochondrial disorders, and every year she had celebrated her child's birthday as if it was the last, because she had read that kids with mitochondrial disorder don't have long lifespans. And now that this diagnosis was given upon her reading, she had a whole readjustment that she's going to be with her daughter for a very long time, which gave them happiness. The other thing is, in America and many parts of the world, an autism diagnosis means extra support in school, right? It also means that child has access to ABA, applied behavioral analysis therapy. And because of that, she was able to stay in school with extra support. She underwent applied behavioral analysis therapy, and her aggression improved. And because of the appropriate diagnosis, she was able to attain the appropriate services with improvements in behavior and the main presenting complaint. So the learning lesson from this example is anytime a patient comes, always view it as a blank slate. Don't carry on the previous diagnoses that can add to confounding factors and a confounding bias. The second thing is always advocate for your patients. And if they aren't results in the past, that's a big sign. Any questions before I move on to the second example? Okay, great. We can move on to the next slide. Okay, so this one I actually saw 2 weeks ago. Again, this one was also presented and they came seeking me for a second opinion. So this is a 7-year-old boy, and he was diagnosed with autism spectrum disorder around 3 to 4 years ago. And at that time of the diagnosis, mom was explaining to me that he had had social withdrawal. And this was new. So that's an orange flag. Yes, there can be regression or amplification of autistic symptoms that happens in the early developmental period, but usually research shows this happens between 2 years, and a lot of the presenting symptoms can be noticeable by like 3 years of age. And then the sudden social withdrawal that happened, that's also another orange flag. The third thing is he had difficulty communicating with adults. That's also slightly atypical. With kids with autism spectrum disorder, what we see is they have difficulty communicating with their peers, kids within their age group, and they feel a bit safer communicating with adults because there's social interaction difficulties. The adults tend to be more patient with the children who lie on the autism spectrum. And what was reported to me is he still, even though had undergone social withdrawal, he still maintained good social appropriate friendships with his peers. And so upon taking a thorough history, what we realized is around 3 to 4 years ago, his parents were going through a divorce. And hence he went through that withdrawal. And over some time, he got onto a good relationship with one of his parents, but had difficulty communicating with adults. But when you went into the detail, it was with one specific adult, parent, and that family of that parent. So it was very specific. And so with that realization, we realized he actually did not meet the DSM-5 criteria. In fact, he didn't have any persistent social deficits. He was improving, he was participating, he was rebuilding relationships with parents, and he was in social groups at school. And so that changes how you address the therapy and treatment, right? Now this child doesn't go from applied behavioral analysis, they go to specific psychological interventions that seek to unify and create those rebuilding of relationships with family therapy. And so what he had at that time was adjustment disorder. right? A significant trigger or stressor that was hard to adjust with. The other thing is, while the adjustment disorder doesn't last, because now we're seeing him 3 years later, he still had symptoms consistent with anxiety. And that's why he needed help. But when we really looked into, other than the anxiety, he had great social parameters with his peers and his teachers. Any questions before we move on to the next exam? Okay, we can go to the next slide. So, what is the differences in the two examples? It's really key to understand the diagnostic criteria of autism spectrum disorder. Once we have a clear understanding of the diagnostic criteria, it can minimize some of the challenges that go in understanding some of the mimics. And so how did DSM-4 and DSM-5, what were the changes? The most significant changes, the kids that were diagnosed with Asperger are now within this whole spectrum of autism spectrum disorders. So instead of distinct diagnoses, these are now a part of a spectrum. And they're persistent. It's not temporary, just like the second example I showed you, that child had temporary deficits, right? So these are persistent deficits in 3 areas of social communication and interaction. On top of that, you need 2 out of 4 types of restricted repetitive behaviors. So 1 includes deficits in social and emotional reciprocity. So what does that mean? That means that when I talk to you, then I wait and then I listen to you, the other person, and there's a reciprocity and then I react to it. So there's a to and fro. There's a ability to share interest. There's ability to understand sarcasm, jokes, and emotions and display empathy. The second thing is deficits in nonverbal communicative behaviors that are used for social interaction. So this was the other thing that was very notable in my patient who ended up having Clave stress syndrome. There's a lot of misconception that when I give talks in our community and amongst our pediatricians, that a child to meet criteria for autism spectrum disorder, they need to have minimal eye contact. But that's not necessarily true. We have a lot of patients who are high functioning autism who do maintain eye contact, especially when they feel safe with the caregiver or parent or that one friend that they grew up with. The key is unsustained eye contact. So as I'm communicating, am I able to sustain my eye contact in a social appropriate manner? Pointing skills. When I consult patients and teach physicians in other countries, one of the frequent questions I get is, well, in our culture, we don't do a lot of pointing. And I was like, that's fine, but how is this child trying to relay their needs, even if there's a speech delay with their nonverbal communication? Are they able to display to you that when they want milk, are they using appropriate hand gestures to communicate with you what they need? And when there are deficits, when a child wants that milk but is unable to look towards it or show through hand gesturing, where that milk is, and the parent is unable to even decipher what this child wants through their sign language, then that becomes very discerning for the parent. And most kids who do not meet the criteria for autism spectrum disorder and have speech delay, in fact, they overcompensate by nonverbal gesturing. And then the verbal communicative behaviors can involve echolalia. For high functioning patients with autism, I often see and hear from parents that they give very rehearsed answers. What did you do this weekend? I went to a birthday party. Because they've learned that masking behavior, that now this person will stop asking me once I give that answer. However, okay, what did you do the weekend before that? Went to a birthday party. And then the parent tells me, that never happened. So even with a verbal communication, and ability to create phrases and conversations. There's a type of echolalia and a rehearsed pattern and repetitive pattern that comes with it. And then deficits in developing, maintaining, and understanding relationships. We have children that are very close to a parent or an older sibling, but are they able to understand relationships? If they're an older child, are they understanding the complex friendships that are now expected at that age? For high children that then enter high school and haven't been diagnosed or have had misdiagnoses, that's really when the symptoms start flaring up, because now school assignments are teamwork. And so the understanding of those relationships, the expectations are higher. And that's when a lot of kids who are on the higher functioning side of the spectrum, that's when they end up getting their diagnoses, because they kind of fell and slipped through the cracks. Next slide, please. Next slide, please. Thank you so much. I really appreciate your participation in helping with the slide navigation. So with this, you need 2 or 4 stereotypies. So like flapping hands, rocking your body, insistence, like if a routine is not followed or the same thing is not done, having extreme reactions to small changes, or playing with toys in atypical manners instead of rolling a car, just fixation on the wheels and rolling those wheels, or being upset with certain textures of food or what's put on the skin, or I have some patients that don't feel that much pain. And so for that, you need 2 out of 4. Next slide, please. So now that we have a better understanding of autism spectrum disorder, let's go to the mimics. Now, the mimics I've decided to speak more about are the ones that the PCPs and other neurologists within our field will refer these children to me for. Now, ADHD, it can occur in isolation. It can occur with autism. And that makes it even more difficult, right? But it's very important to differentiate for treatment options, right? Someone with ADHD, ABA therapy is not the help. Someone with ADHD and ASD, ABA therapy, applied behavioral analysis, can help with both. And then in terms of medications, right? Someone with ADHD, they do really well with stimulants. Someone with both and behavioral issues, something like methylphenidate can hyperactivate the child with ASD, hyperactivate their stimulatory behaviors, and make their aggression worse. And so in this case, something like guanfacine, which is not as stimulatory like Ritalin, may be helpful. And so how do you really differentiate it when there's a huge percentage of kids on the spectrum that can also have ADHD? Depending on different researches, it's quite significant, 50, 70%. And so kids with ADHD, the key difference is they are not going to have issues or challenges with maintaining relationships when they're having fun, right? So if they are playing with their friends in their favorite activity, they are going to be able to maintain appropriate relationships. They are going to understand empathy. They're going to understand sarcasm. Typically, there's not going to be a history where there's going to be issues in deficits in gesturing, right? And so that's the key. Someone with ADHD but doesn't lie on a spectrum, they shouldn't be significant challenges with understanding social cues of nonverbal communication. And then with autism spectrum disorder, remember we went over the criteria. Yes, there's a sensitivity in reactions to emotions, but impulsivity and hyperactivity, it's not a part of the diagnostic criteria for ASD, right? Whereas hyperactivity and impulsivity in 2 or more settings is the diagnostic criteria for ADHD. So that's what I teach our medical students as well. If there are no further questions on this, I'll go to the next slide. Thank you. Okay, so mimics. The second thing I get asked a lot about is obsessive compulsive disorder. So what also makes it interesting is there is also association with ASD and OCD, right? And the basal ganglia, the thalamocortical circuitry, they're both associated in ASD, ADHD, and OCD. The percentage of OCD in kids who lie on the spectrum is 17%, so not as high as ADHD. Now, someone with OCD but does not have autism, outside of their periods of having those obsessions and compulsions, there should be no challenges that are significant to cause impairment with their social, verbal, and non-verbal interactions. Right? Now, someone is having an obsession and a compulsion and they have to count till 50, 60. They're not going to give that social reciprocity when they're having that compulsive thought or action, right? But once they overcome it, once they feel like they finished counting till the number that gives them that feeling of peace, they go back to social appropriateness. So that's one way to differentiate it. That's actually the most important. When it comes to intellectual disabilities, intellectual disability is also another diagnosis that had a significant change between DSM-4 and 5 criteria. In the prior diagnostic criteria, numbers were really important. But guess what? Nothing is as it seems in life, right? We can't box kids up. And so someone who had mild ID, so a score like that was maybe 52 to 69, if they had significant deficits in verbal reasoning and executive functioning, they didn't get the appropriate services. So now the DSM-5, it's more accepting on how the child is really doing. So what are their verbal reasoning skills? What are their adaptive functioning skills? And based on that, it's mild, moderate, severe, profound. So how do you do that in someone who has severe autism? How do you appreciate intellectual disability? And also the other way around. How do you discern intellectual disability in a child with severe functioning autism spectrum disorder? So the way to do it is if a child with autism also has intellectual disability, is that disability more than their autism level of functioning? So if something is in discordance, if something is in excess of that level, that's when you know that it is an accompanied diagnosis. I have a lot of high functioning patients with autism that really know how to thrive. And when they go ahead and get their psychological testing done, their IQ scores are pretty high. The same way, I have kids with moderate intellectual disability, but have really good use of nonverbal and verbal communication. Going on to specific learning disorders. So specific learning disorders, sometimes these kids can have low self-esteem, get withdrawn. And so are they shining in arts? Because they love arts, but now in maths class, they're socially withdrawn. So really partnering up with school, getting a history from the teachers is equally important as well as getting history from the parents. And then social pragmatic communication disorder. We love talking about this now, right? Because it was talked about in DSM-5. But the theory really is very few patients, and actually I haven't seen any in the past 2 years, that don't end up, when you really dig in deep, don't have restrictive RRBs, you know? So social pragmatic communication disorder, the way it differentiates from autism spectrum disorder is they're not going to have that B criteria. So it's going to be issues with communication, but they're not going to have stereotypies. They're not going to have that rigidity. They're not going to have that inflexibility. Any questions before I move on? Okay, next slide.
Is there any guideline as to what intellectual ID testing, is it different? Are there different tests that give us better input than the others? The testing is indeed difficult. And then,
yeah, so that's such a great question. There's a lot of IQ tests, right? There's the Stanford Bennett IQ testing, there's the Wessler IQ testing, there's Bailey's. So that's where the biases come, right? Are those IQ tests culturally tested? What may be great for one culture may not be reproducible with the similar scores in another one, right? Schooling systems are different. So are the expectations that this score is made with this answer in this country, this is what's expected at this age. So we do know that IQ tests are many, but we have to also, as the future goes on, make sure that these IQ tests are representative of all our kids, not just a specific country or race. The second thing is the comfort of the examiner, right? Psychologists may be really comfortable with Stanford Binet and not Wechsler. And so you need to make sure that as a tester, you're comfortable with it, you have enough experience with it, and you're retraining yourself because a lot of them have newer editions. Any other questions before I move on? Okay. Well, Dr. Hilal is going to talk about the mood and anxiety disorders, but we had example 2 where it was adjustment disorder, right? And we went into details why that child did not meet the criteria for autism spectrum disorder. There's some research that says kids with autism, around 80 to 85% of them will have anxiety. The key is someone with anxiety without autism spectrum disorder, you really have to go into the developmental history. As they're developing, before the anxiety manifested, they shouldn't have had those 3 persistent deficits in communication. Kids with anxiety can fidget, they can have stereotypies, but they're not going to have those specific fixations unless it's a common behavior learned with anxiety. With depression, there's a lot of flat affect, and you have to become comfortable with understanding what is flat affect versus and not being comfortable or having deficits in relaying social emotional reciprocity through facial expressions, right? So understanding what is unsustained eye contact due to a social deficit versus a flat affect that is a masked sign when experiencing depression. And then it's very confusing with kids who have social phobias because their deficits are and their fears come with social interactions. But for these kids, typically social phobias will manifest at a later age, whereas most kids with autism spectrum disorder, you're going to see those social deficits in the beginning. The second differentiation is kids with autism spectrum disorder are going to have restrictive interests, stereotypies, sensory issues, where typically that is not seen in a kid with social phobias. And again, social phobias can manifest typically later on than the symptoms of autism. Any questions before the last slide? And I think I'm keeping good with my time, Dr. Hilal, maybe 2 more minutes, yeah? And I've kept it within the 20-minute mark. Okay, next slide, please. Next slide, thank you.
No, I'm trying to do actually, it got, I got hanged, that's why 1 second. Yeah, I'm so sorry, it got hanged. And that's
No,
why even
I'm
the
just
previous time it did.
thankful.
I said there are 2 questions. No, there are a few questions also there in Q&A. We can just take it after we have the experts speak after that. Yeah, sorry, actually I'm there. The only thing is, yeah, sometimes it decides to hang itself. So sorry
Yeah,
about it. Yeah.
we're definitely seeing this, right? It's exciting. We have so many participants, but we're seeing that technology is not up to par, but maybe the next one. Okay, last slide, key takeaway points. Remain receptive to the possibility that patients may meet the criteria for more than one diagnosis, right? If I have a patient with autism, ADHD, and OCD, and I only focus on helping this child thrive with their autistic symptoms, and I ignore the ADHD and OCD, and even the diagnosis may slip up, I'm not supporting the child for them to thrive in life. It is crucial to regularly reassess their condition and follow up accordingly. You know, sometimes it's easy to get honed into one diagnosis and just think that's the explanation for all the symptoms. I see this typically with kids who are trisomy 21, when they also have autism. And you know, the doctor can say, oh, this is just trisomy 21, this is just because of Down syndrome, oh, this is associated because they're globally developmentally delayed, oh, this is because they're severely intellectually disabled. And when one stops and says, well, we assume that this child has ASD, but we haven't done the psychological testing, let's do it, let's support this child. And now we've given them a diagnosis of autism. Great. Now insurance is going to approve ABA therapy, which this child with Down syndrome and autism spectrum disorder deserves, right? And pay earnest attention to any new complaints raised by parents and caregivers. My first example, the child with Kleefstra syndrome, that complaint was going on for 3 years. And so the question was, any reassessments, those autistic behaviors may have been picked up much early on because she was displaying them as young as 2 years of age. And then vigilance against diagnostic, anchoring, and cognitive biases is essential for preventing misdiagnoses. And even when you have the correct diagnoses, not to miss additional ones that are associated with the one that you gave this child. Thank you so much for having me. And I will hand it off to our next speaker.
Thank you. Before that, too, I will ask Lokesh to
Yes.
ask the experts.
So, thank you, Dr. Tuba, for the excellent talk. So, I will invite comments from our experts for today, Dr. Veena Kalra, ma'am. Your speaker is off.
All right. So it was an excellent talk coming straight from personal experience and really highlighted the need to assess these children multidimensionally. Also needs to recapitulate their symptoms and go back and reassess them. It was really a good demonstration of that. And I think it also indicated very nicely how genetic testing can fine-tune our diagnosis of these disorders and help us give the family a clearer prognosis and outcome of the illness. She outlined the spectrum that confuses us beautifully and also how to intellectually test them, which is indeed a challenging task in children with autistic spectrum disorders because they don't comply with the usual tests. Thank you, Dr. Tuba. Really enjoyed your talk.
Thank you, ma'am.
Thank you so much.
Biju Amit, sir.
Thanks, Lokesh. Thanks, Dr. Tuba. That was a fantastic talk. And I think the talk was fantastic because it highlighted all the key points. From personal experience, I think the two things, one which Dr. Veena Kalra ma'am asked and what Dr. Tuba mentioned, how to diagnose intellectual, to me, the biggest mimic is intellectual disability. And when intellectual disability coexists with autism, or when intellectual disability is on its own, that's where all the difficulty is, particularly because the age at which we are diagnosing autism has now come down to, like in our institute, it is 24 months, but there are institutes where it's diagnosed as early as 18 months, and rightly so because of the need for early intervention. And I think the answer to Dr. Veena Kalra ma'am's question as to how do we diagnose intellectual disability, I think the key thing is as more and more children are being referred from primary care for diagnosis of autism, and as we know that most of these children have got intellectual disabilities in the milder to moderate range, there's increasingly a huge number of physicians who are not really equipped to make that difference to differentiate between intellectual disability and autism, and hence the need of the hour for more training. And I think in these sort of situations, an integrated multidisciplinary approach to diagnosing autism is the only way that you can really tease out these children. And that's why I strongly feel that particularly in these sort of complex children, they should be diagnosed in centers where there is the appropriate expertise for doing so. And we know that when the intellectual disability is present alongside, the the risk of having an underlying genetic disorder is very, very high. And that early diagnosis is also important. Like a typical example would be phenylketonuria. Like if you diagnose it quite early and if you treat, then if you look at the incidence of autism in phenylketonurias who have been diagnosed, the incidence is very low just because they have been diagnosed early. So similarly, like whenever you have that intellectual disability, then it's so important to send these children for genetic diagnosis, particularly the the variants rather than like monogenetic conditions. So I think the key take-home point from Dr. Tuba's talk was yes, the ADHD is important, and similarly the children with intellectual disability. And I know DSM-5 has got allowance for even making intellectual disability diagnosis on its own, and it doesn't really go further than how to differentiate between autism and intellectual disability. Really, other than just saying that, like, things which are not explained by the intellectual disability, as Dr. Shefali also mentioned in her one of her slides. So, fantastic talk. Thanks again, Dr. Chuba. Thank you.
Thank you, sir. Dr. Lokesh, sir.
I think, Lokesh, it's already time. I think there's
Yes,
already
yes.
lots of things have been covered. We can move on to the next one. Thank you.
Yeah, just 1 second. I'll just interview. Actually, this it is being discussed, so I just skipped that slide actually, but I think it will be important to share. I had just mentioned it in the passing, but I think that there is I think I need to show this slide again just because it's important. And as Dr. Tuba has said that ADHD, yes, in our patients also around that 1874 patients, 55.7% had ADHD. So this one was, I had just mentioned 2 lines from these 2 slides, but I think we need to go through the points that are important. Although the criterion E of the DSM-5 requires the disturbances are not better explained by intellectual disability or global developmental delay as the age may be, but there is no description anywhere how it should be determined. When the ID is so severe that the clinicians apparently find it impossible to identify the relative deficits in social communication and play, given the extreme low mental age. The mental age associated with the ID with the severe to profound range of ID may not exceed 18 months, an age which is not maybe possible to assess certain abilities like spoken language. And the autism diagnostic interview revise and autism diagnostic observation schedule are far less specific when used for individuals with non-verbal mental ages below 15 months. And the second part was the criterion E, which again was requiring that the disturbances are not better explained by ID or global development delay, and severe ID may prevent a valid assessment of certain ASD symptoms, as I mentioned, and the limited social responsiveness, and the interfering repetitive behaviors and other behavior problems like hyperactivity, aggression, and inattention common in children with ASD complicate the cognitive testing in this group and potentially leading to lower score on the other side. And individuals with various genetic conditions and neurodevelopment disorders are likely to have motor disabilities, ataxia, also associated problems of epilepsy and sensory impairment affecting vision and hearing. These further complications complicate the application of criteria. And the non-verbal communication behaviors that typically emerge in early development, such as eye contact and facial expression, gestures, as well as the capacity to share enjoyment and participate in simple back and forth games and like peekaboo, are more specific to ASD. So I understand and I totally agree the dilemma which we have on a day-to-day basis. Sorry, I thought because I had not talked in detail on that, and this was something. And Dr. Tuba, thank you so much. It was an amazing presentation with your hands-on experience. That is what matters the most. I think Lokesh, I think Dr. Hilal, you can start sharing your slides. So now, from a pediatric neurologist point, in a high-resource setting, we come to a psychiatrist in a colleague in a similar low-resource setting like ours.
Thank you. I am audible, madam.
Yes.
And I think my slide will be here. And it's my great pleasure that to say something in front of the legendary professor in this field, like Professor Kalra, and also one of my mentor, Professor Gulati madam. And it's very good and very uh, uh, easier for me to say because the already Dr. Tuba Khan, she said very elaborately and very precisely from her experiences and the DSM-5, also the mimics of the autism regarding the other case history. So I think I will complete it before the 20 minutes. So the autism mimics from the perspective of the child psychiatry, because there are some conditions and some symptoms, they are also overlap with the autism and other conditions of the child and adolescent mental health. And the misdiagnosis in two ways. Not on the mimics, I think there are some misdiagnosis of the autism in the two ways. The first, the person have autism, but diagnosed as other disorder. And other way, the person have not autism, but at all, but diagnosed as autism. That means that we have wrongly diagnosed autism or we have missed the autism. This is the two-way misdiagnosis in case of uh, child autism and other confusion with the other psychiatric disorder. And autism mimics, there are two types of mimics we found. One is the only the symptoms, not the conditions, not the disorder. Symptoms of autism, but not autism. And another disorder mimics autism, but not autism. And autism-like symptoms, but not autism, that we found that the poor eye contact and impaired social interaction in the children with the ADHD may have the impaired social interaction due to their impulsivity, poor eye contact as a result for their distractibility, but they have no autism. They are very similar symptoms with autism as they will start and sustain social interaction in case of ADHD and can have a back and forth reciprocal interaction. And there are some talkativeness also there. So the poor eye contact and impaired social interaction is the not form of the autism. It's the different form in the ADHD. But conversely, the child with autism may not be able to start, not sustain a conversation unless it is a topic of special interest to them. The social reciprocity or back and forth interaction is missing with autism, but it is there with the ADHD children in most of the cases. There are some differentiation, there are some other things, but it is the most of the cases there are some reciprocity present in the case of the ADHD. And another symptom that is the social withdrawal and the isolation. And the social anxiety disorder, we can call the children to be the shut down with regard to the social interaction. They're the totally shut down from any social interaction, but they can interact normally in a comfort zone. If we provide a comfortable environment to them, they will show social reciprocity. But a child with ASD unable to this in anywhere, not in the comfort zone, not in the unknown place, not in the strange, anywhere, they are very distracted and social withdrawal. But in the social anxiety disorder, if we provide them the comfort zone, their social withdrawal has been already gone. The selective mutism as well as can be mistaken for autism. And the teacher in the classroom may erroneously think the child has autism. It is mostly found in the community and in the school setup, but not in the home setup. That is, they are very much isolated and socially withdrawn. And typically developing children can certainly have anxiety at times. Look for a family history for anxiety or other any psychiatric disorder like the anxiety, obsessive compulsive disorder in the family, then the social withdrawal and isolation can be there. And another term we know, the reactive attachment disorder in children, they can also show the withdrawn, detached, avoid eye contact, and physical touch. And they also misdiagnosed with autism. However, they have the typical social interaction appropriate for their age if they feel comfortable. So there the difference, main difference is the external milieu of the child, that the comfort zone present or not. And third symptoms, that is the repetitive behavior, the lining of the toys or walking on toes like these, the repetitive behaviors in children with OCD, obsessive compulsive disorder, may line up toys and not be on the autism spectrum disorder. It could be due to their anxiety and a need to have control. So we have things that by this way, the repetitive behavior, the child mitigates his or her anxiety, but not in the autism. That is the repetitive activity going and ongoing, and it is almost very long, continuous. The OCD children can have normal social interaction and reciprocity, but in autism spectrum disorder, they have no normal interaction in the most of cases, and most of the cases, the lack of reciprocity. The toe walking that can be become a habit in commonly outgrown and does not mean automatically that the child is on the autism spectrum. That also the difference between the other symptoms with the autisms. And speech delays we found in the autisms, hearing problems or other developmental delays also can mimic with the symptoms of the autism. That is the oral motor problem, hearing problems and or intellectual disability can show developmental delay. So we should be differentiate between this, the intellectual disability and the autism by some way. In the context of the eye contact, in the autism, there is a lack of eye contact or the avoidance of the eye contact. And but in the intellectual disability, the child has eye contact, but most of the time the eye contact is the meaningless eye contact. There is no meaning, there is no reciprocity of the eye contact, but they have the eye contact. That's the one of the differentiate. And autism has communication and social interaction problem, including language developmental issue, but rarely have hearing problems and not found in organic cause for these issues, the language development issues, and ruled out of any nutritional, organic, or congenital cause of developmental delay if necessary. So we have to assess, reassess, and if need, some laboratory investigations also needed. And there are some conditions that mimic the autism. Previously, I said some symptoms, now the conditions. The first, I want to give uh, some talks on the schizophrenia. Both the schizophrenia and the autism involve the cognitive and sensory processing problems. We know the autism has some sensory issues. Both seem to run in families and both include atypical brain development. But individuals with autism do not have delusion or hallucination at all in the most of the cases. They have no the paranoid ideations or not the very vivid hallucination, especially they have not the auditory hallucinations. Other hallucinations sometimes they have produced. That is the differential diagnosis with the schizophrenia. But we said the critical component of schizophrenia. We said the first rank symptoms of the schizophrenia. And there are some thought disorder, the formal thought disorder in schizophrenia, that is the thought insertion, thought withdrawal, or thought broadcasting. But in case of autism, there is no same sort of the formal thought disorder we found. And the schizophrenia is usually diagnosed in young adulthood, where autism is diagnosed in childhood. In the very rare, the schizophrenia occurs before the age of 9 or 10. Rarely it can occur childhood, but after 9 or 10 years, it is mostly the symptom occurs, and most common age is the 15 to 29 years for the schizophrenia. But autism is at the age of mostly the developmental age, and mostly around the age of 3 to 4 years of the age. And learning disorders, especially the specific learning disorders, we know that dyslexia, dysgraphia, dyscalculia, that's the difficulty in the reading, writing, and arithmetic problems. And that is also a common mimics with the autism spectrum disorder. The children with autism will also struggle with the learning. They are capable of intense focus and comprehension on a topic that entails them. But autism is a disorder of developmental that mainly involves social understanding, communication, and repetitive routines or behaviors. Already, Professor Gulati Madam and Tuba Khan also described the DS criteria, that including narrow and obsessive interest in some cases we found in the autism. And another very mimic condition, that is the ADHD. There can be overlap in the symptoms of autism and ADHD, difficulty in focusing, hyperactivity, and impulsivity. And we found that the autism has the comorbidity with the ADHD and autism, two separate double diagnoses. But we found not fulfill the criteria of the ADHD only the hyperactivity symptoms in the person with the autism spectrum disorder. So the hyperactivity can be a part of separate entity of ADHD in the autism, or only the hyperactivity symptoms in the autism spectrum disorder, not fulfill the criteria of the ADHD. While the children with ADHD will resist order and repetition, these things can be comforting for a child with autism. A child with autism may be reluctant to speak or engage with others unless they are talking about a topic that interests them. But in case of ADHD, they are always talkative in many issues. They are talkativeness, and they are try to talk. With ADHD, child will impulsively speak often and interrupts others, especially the caregivers, parents. They did not give some talk to others, always interrupt to others. They are talking. There, the attention deficit disorder and autism, there are some differentiate. That is, in case of autism, difficulty focusing on non-preferred activities, but hyper focus on activities or interest. Some they have some interest in some activities, specific activities. They have hyper focused, but in case of ADHD, individuals may hyperfocus but prefer tasks that they do not require sustained focus. The work they need some attention, they always avoid. In case of autism, might struggle to pick up on social cues unless these interactions are a special interest, may struggle with the word finding and verbal communication, may have difficulty with filtering in case of ADHD, what thoughts they want to share, and they might interrupt frequently or impulsive other conversation already I have mentioned. And in case of autism, may craft specific routines they might be difficult for others to follow, and they might experience anxiety or distress if the routine changes. They are very much stereotyping in their own routine and try to confine within their own routine. But in case of ADHD, thrive with a consistent routine but may struggle to follow a routine due to disorganization. Always they are distracted and they are hyperactive and they are lack of attention. And other conditions that mimic with autism, these are the not very related with the psychiatry. These are more related with the childhood neurodevelopment neurology, that the Reed's disorder, the chromosomal disorder, Fragile X syndrome, LK syndrome, Angelman syndrome, Prader-Willi syndrome, and Williams syndrome. I don't want to elaborate. These are more. And this is my last slide, that what to do to prevent the misdiagnosis. How can we prevent the misdiagnosis, and how can we differentiate the mimics, the autism, and other disorders? That is, the first elaborate history taking is very much important, and cross-check the history with other family members. Not depends only one key informants. When the mother or father or any other informant give the history, it will consider, but we should take cross-check the history, and also cross-check the history of the teachers in the relevant cases, those who are in the school going. Then we can make the history taking a meaningful. Always cross the history taking with other family members rather than primary informant. And also the psychological assessment is very much important. Psychometric test in especially in the multidisciplinary approach we have to follow. All the neurologists, psychologists, psychiatrists, a team, some psychological assessment when you need some diagnostic tools, we can follow that. So this is another way we can prevent the misdiagnosis. And we need clinical assessment. That is the neurological assessment. And also, assessment is not fulfilled. Always we need the reassessment and reassessment and reassessment for the children to diagnose autism or any other childhood mental disorder. Relevant laboratory investigations also needed, including the chromosomal analysis and other issues, and assessment of the adaptive skills. When we think about the intellectual disability or the pragmatic communication disorder, we have to always assess the adaptive skills by some tools, and speech and language assessment and reassessment. Especially in case of, we found that some cases, there are some child abuse, physical abuse, sexual abuse of very small children. They have some suddenly developed the speech and language difficulties. So you have to assessment, take the history, and reassessment is very much needed. And when there are some very confusion with the diagnosis, we have diagnostic dilemma. We have to admit the children at the hospital for observation, and establish a diagnosis by following the diagnostic guidelines. So these are my talk. I think I'm trying to make it very simple, not too very elaborate and theoretical. Thank you, madam, for giving me the opportunity. Say my talks in this gathering, and also happy Eid Mubarak to you all. Thank you, madam.
Thank you, Ahmed, sir. For the want of time, we will straight away go toward the case presentations, and then we can ask the comments later after the case presentations. Thank you, sir. Thank you for the excellent talk. Or I invite first presenter for the today, Dr. Isra from Turkey.
Lokesh, just after
Yes.
after Isra's talk, we will take the expert comments and the Q&A as well. Yeah, the which are there in the chat box. Huh? So, and I
Yes.
request, yes, because then it may be difficult. If anybody has to, the questions should be taken after. Because you
Sure.
just started after Isra's, we can take the comments from the experts as well as the Q&A box things. You can just consolidate how you want to ask. Yeah, Dr. Isra, please.
Hello, everyone. Can you see my slides?
Yes.
Okay. I'm Dr. İsra Sarıgeçili. I'm working as a pediatric neurologist at Adana City Training and Research Hospital. Before starting my presentation, I would like to thank wholeheartedly to Professor Dr. Hasan Tekgül for his endless help and support to me and giving me such a big opportunity. Today, I'm going to tell about that two siblings. I'm sorry. Okay. Two siblings with speech delay and autistic features were diagnosed with a rare muscle-eye brain disease, B3GALNT2 gene mutation. Oh, but I'm not able to move it. Okay, there's no problem. My case is two siblings with age of 4 and 8 years were followed up with autism by the child psychiatry and pediatric metabolism outpatients for 3 years. Their complaints were having seizures, myoclonic and atonic characteristics, involuntary hand, head, and arm movements. They had mental and speech retardation, socialization problems, and they don't have any eye contact. Their prenatal, natal, and postnatal periods were unremarkable, and there is a 1-degree consanguinity between parents. When we look at their physical examination, they had involuntarily hand, head, and arm movements. They had no eye contact and socialization. They had mental retardation and they were walking on their toes. Their deep tendon reflexes were brisk, 3 positive, and they had no pathologic reflexes such as Babinski and Clonus. On their lab results, routine biochemistry test results such as creatine, uric acid, sodium, potassium, liver function test, and hemogram, B12, thyroid function test, iron and ferritin were all normal. When we look at their metabolic screening test, tandem mass, uric organic acid, lactate, provate, homocysteine, and biotin, lysosomal screening test, and very long-chain fatty acids were all normal. And other laboratory test results, hearing test, visual evoked potential test, and electromyography were all normal. When we look at their EEG, there were multi-spike, wave, and discharges generally in myoclonic characteristics. As we can see on the screen, almost there were generalized multiple spike and wave discharges are seen in this in their EEG, and therefore clobazam and levetiracetam were started to patient, and now their seizures are under control. When we look at their brain MRI, as we can see on this picture, there is leukodystrophic changes on their MRI on the coronal, axial, and flare sections. As we can see, there is a clearly seen leukodystrophic changes, and we can see in this pictures leukodystrophic changes about both patients. And their MRI, their MRI was reported by our hospital's child radiologist as a metachromatic leukodystrophy. But when we evaluated our patients again and again, his history, his laboratory results, and his physical examination didn't fit in with metachromatic leukodystrophy because they didn't have any neurodegenerative process and their all metabolic screening tests were normal, and their main complaint was autistic features. So we didn't assume that, we didn't consider that as a metachromatic leukodystrophy. So, and we examined them again and again, and we noticed that their creatine kinase levels were always moderately high. As you can see this on this arrow, their creatine kinase level ranges from 211 to 392. They are moderately high in both patients. So, as all of these results, we suggest that we consider that they should be a muscle-eye brain disease. So we decided to get studied whole exome sequencing test, and after whole exome sequencing test, B3GA-LNT2 gene variant homozygous mutation was detected in both patients. As we can see here, homozygous gene mutations, which is related to muscle-eye brain disease, alpha-dystroglycanopathy, was detected in both patients. And both of the parents are carriers of this genetic mutation. After these findings, genetic counseling was given to the family. And the siblings are followed with epilepsy and offered special education support to them. I'm gonna tell about a little bit congenital muscular dystrophy in here. I'm gonna be very fast as soon as possible. Congenital muscular dystrophy is a disease.
Dr. Isra, please, you can conclude the slides.
Okay. Okay. In summary, in our patients, both of them had speech delay and autistic features, mild neuromuscular features without ocular involvement, non-classical white matter involvement without kyst or lissencephaly or cobblestone malformations. They had normal electromyography features, and they had mild creatine kinase elevation. In summary, creatine kinase level should be checked in every patient with autism. If patients with autism are accompanied by moderate creatine kinase elevation and leukodystrophic changes on brain MRI, the probability of detecting B3GLNT2 gene mutation is very high. And I would like to add a little thing. Genetic testing with next generation sequencing technology provides rare genetic disorders. Thank you for your attendance, and I would like to take attention to Autism Attendance Day, Autism Attendance Month. Thank you.
Thank you. So, Dr. Hassan.
I'm sorry for the video. I'm sorry. I didn't recognize. Okay.
Sir, this will be mailed to you. Thank you so much for a wonderful presentation. Dr. Hassan, your comments. Thank you so much. Huh? Sorry, we have so we had to cut short. Yeah, it's running short. Dr. Hassan? Dr. Hassan is there.
Thank you, Dr. Shefali, Dr. Lakesh. And then Esra, congratulations for your nice presentation. I really enjoyed that your passions this time. Dr. Ahmed clearly mentioned that the patient has autistic traits, but not autism diagnosis. So this case, your cases present of leukodystrophic pattern, complicated, and then cover the muscle disorder. So we have to be think about if the patient has autistic traits and autism, we don't explain. We didn't get any response with the treatment, so we have to get the MRI examination, and also we have to make a screening. You mentioned that creatine kinase elevation. We may think about the congenital muscular dystrophy. Thank you very much, Esra. Thank you, Dr.
Thank
Shifal.
you.
And
Thank
Dr.
you.
Rakesh.
So now I invite Dr. Tuba to comment on this case, and then we can ask questions regarding her presentation to her.
Okay. So I thank you so much for presenting such a wonderful case, and it really is an important topic. This is not new research. We've known this for 5 to 8 years now, and possibly even longer, that a lot of the genes and a lot of the proteins that are seen to be the problem in muscular dystrophies have important roles in cognitive function. Dystrophin plays an important role in executive functioning. And so now it's not surprising that a lot of muscular dystrophies are associated with autism, cognitive issues, and intellectual disability.
Thank you. Thank you. So there are many questions regarding your talk, and I will ask a few of them, and there are comments also, but I will be asking questions to you. So one of the question is, how confident can one be about making social communication deficits for children 2 to 4 years of age?
Yeah. So it's always good never to be overconfident, right? There's a reason as physicians, we have follow-up appointments. If we were so confident, we would just have that one visit and say bye, follow up with the PCP. In many cases, especially if the child is on the moderate to severe side of autism spectrum disorder, we can see symptoms as young as 11 months of age. The youngest child in my team that we diagnosed was actually 10 to 11 months of age. Because think about it, right? That cooing, that social smile, it's developed around 2 to 4 months of age, right? Cooing, we know 2 to 4 months. And then that smiling at mom and dad, that's like by 6 months of age. So there are social cues picked up even in infancy. And then babbling, also happens around 6 months. And even with the babbling, the child is looking at the mom, looking at the dad, expecting a reaction. Peekaboo is also like within the first year of life. And so when a child is not meeting any of those markers, that's a red flag. And so for those kids, one can have a pretty high suspicion for autism spectrum disorder, and with appropriate testing and clinical expertise, we do give the diagnoses of communication disorders and autism if they meet the full criteria.
May I just add, Lokesh, with your permission, I wanted to share that, Tuba, we have developed the autism early screening tool by AIMS, and we have for 0 to 18 months, and that you have 0 to 6, 20 questions, 6 to 12 months, 20 questions, and 12 to 18 months, 21 questions. And then you have, around 90% is the sensitivity of picking in the 12 months, and it's 98.9% at 18 months. And obviously, so US, as you very rightly said, you can suspect as early in the first 6 months as well. So that is there. So we have a social culture sensitive tool which we have developed.
Yeah, technology is really catching up in research. A lot of countries are now doing these eye tracking testing that can have high predictability of autism in the first year of life.
Absolutely.
So another question is, are there IQ tests specific to autism to account for different intelligences?
Yeah, so, for autism, you have ADOS, right? The Diagnostic Observation Schedule. And then you also have CARS, the Childhood Autism Rating Scale. Those are very specific to autistic symptoms. In terms of IQ, when there's a difference, a lot of the psychologists I've worked with, they've always talked about, instead of doing the IQ testing, do scales that test for adaptive function. Because when you really can relate to the school, to the parent, this is your adaptive function of your child, then they know the next steps. So the test that the psychologists end up doing when they want to have an idea of both is the Mullen scale. So those developmental testings, those adaptive function testing, which actually has really met up, because now we have talked about DSM-5 criteria for intellectual disability is more on adaptive functioning than it is on scoring. There are cases where you can do both tests, right? An IQ test and an autism test, but then how do you bring them both together? So I really think we are in a time where adaptive testing and relaying and understanding the child's situational skills, life skills, how they thrive in school at home is the important thing to do.
So one last question to you. Does a gluten-free and elemental diet has a proven role in autism? And what is your experience regarding these interventions besides the routine interventions we do?
Yeah. Look, we know that a lot of kids with autism are at higher risk for GI issues, right? And so if there's constipation, the child with autism is not going to be happy, right? They're going to have more behavioral outbursts. They're not going to thrive in their therapies. So if someone is truly gluten sensitive, you want to deal with it, right? If they've proven to have those antibodies and markers, we don't want them to be nutrient deficient, because that's also going to delay how they catch up to therapies. Now, I have some patients where they don't meet the criteria for gluten sensitivity, and some of the parents have tried it. I mean, it's not a harmful diet as long as it's healthy, balanced. If the parents subjectively feel that it's improving the behaviors, go for it, right? It's not a harmful thing. In terms of iron deficiencies, we do know iron deficiencies worsen cognitive behaviors, they worsen sleep. So it's always important to routinely, by our pediatricians, test ferritin levels in kids with autism and all kids.
Thank you. So one last question to Ahmed, sir.
Yes, please.
Sir, one of the audience have asked that, like, do we see recovery near, like they recover with a very good recovery and lead a near normal life? In your experience, have you seen such children? And
yes,
what percentage lead independent school life? So there are two separate questions.
Thank you. Actually, there is no such survey in Bangladesh, or otherwise the which percentage can school or mainstream school. But we found there are some almost one-third patients of the autism spectrum disorder, they can lead to the mainstream school. And I have some experiences regarding not full recovery, but almost near normal life, and just passed the great exams in the class 10 exam, 12 exam, and entering in the Polytechnic Institute in Dhaka. And also one child is went to abroad for another diploma. So there are some cases in the autism spectrum disorder, especially the high functioning autism, they can lead some near normal life. Not the full normal. There are some difficulties, but they can independent life can lead. We have some experiences and some cases. Thank you.
Thank you. And one question which is like one of the audience have asked, very interesting. Like easy tool to differentiate ADHD and ASD in practical point.
Yes, it should be differentiated the practical at the OPD actually. In the case of ADHD, there are some eye contact, but eye contact is not maintained and not sustained. But in case of autism spectrum disorder, there are avoidance of the eye contact or not eye contact at all. In case of ADHD, there are some talkativeness and interaction to others. There are some impulsivity and also the hyperactivity that. In case of autism, there are some hyperactivity also there, but they're not communicating and not meaningful communication, not reciprocity we found. And that is the mostly we asked about the symptoms. We started first about the what the informant said, which symptoms is more prominent, the hyperactivity or the impulsivity or communication issues or the social interaction issues. So we always need some proper history taking for identification for the, there is some easy way actually the easy way for the clinicians. Thank you.
Thank you, Dr. Ahmed and Dr. Tuba. And now I invite the second case presentation from AIMS Rishikesh, Dr. Diksha Gupta.
Good evening, sir.
You are audible. You can start with your presentation.
Good evening, everyone. So today I'll be discussing a case of CAT6A syndrome presenting as autistic regression under the guidance of Dr. Pradeep Kumar Panda, sir. So beginning with that case, she was Miss I, 4 years old girl, resident of Uttarkashi, under our follow-up in OPD currently. So she had presented to us with complaints of isolated speech delay, following which she had abnormal body movement since 2.5 years of age, followed by loss of acquired milestones since 3 years of age. So she initially had isolated speech delay to begin with, following, as you can see here, that her language domain was significantly affected compared to the fine motor, gross motor, and the social, which was preserved. Following which, at 2.5 years of age, there was acute onset flurry of seizures, GTCS, and myoclonic seizures, occurring 10 to 15 episodes per day, following which the child had developed severe autistic regression with poor eye contact, poor social interaction, motor regression, gait instability, and drooling of saliva. Her birth history was normal, and she was born of a non-consanguineous marriage with no similar history in any of the family members. On examination, she was having microcephaly, and there was dysmorphic features like she had low set ears, smooth philtrum, tented upper lip, and broad nasal tip. However, there were no neurocutaneous markers. As you can see in this video, the child had autistic features, had hand flapping, stereotypical movements were there. Apart from that, she was intermittently closing her ears like that, and she was not responding when she was called. Also, she had reduced interaction with her parents and was just looking here and there. Further, her CAR score was 38 and ESA score was 125, suggestive of moderate autism. We upfront kept the possibilities of developmental epileptic DEs was because of the epilepsy and the autistic regression, specifically involving the motor domain as well. Apart from this, other epileptic encephalopathies like Lennox-Gastaut syndrome, because of the age of onset of seizures being polymorphic with autistic regression, was highly likely. Apart from that, other neurodevelopmental disorders like atypical Rett syndrome was considered, as she was a female with acquired microcephaly, language delay, autistic traits, and epilepsy. However, there was no disorganized, no midline stereotypy, or no gait instability or autonomic features. Other metabolic disorders like GLUT1 and creatinine metabolism defect was also considered because of the speech delay, epilepsy, and autistic features. However, she had no history of worsening after periods of fasting as is seen in GLUT1. We straight away went ahead with MRI, which we reviewed and was done outside. So the T2 friend T1 and DWS sequences were completely normal and unremarkable. We also wanted to do an MRS, but the MRI was already done from outside, so MRS could not be done. In EEG, we could see that there was spike and polyspike waves. Apart from that, there was disorganized background. The spike wave index was 80%, and there was also paroxysmal fast activity. The whole exome sequencing which we had done, that is exome max, which can also detect copy number variations and mitochondrial disorders, which revealed that the child had heterozygous missense variant mutation in the exon 17 of CAT6A gene, which is inherited in an autosomal dominant manner, which leads to CAT6A syndrome, also known as ARTH syndrome, that is Arboleda-Tham syndrome. We treated, apart from the anti-epileptics which we had given her, valproate, levetiracetam, topiramate, and clobazam, the seizures were drug refractory. So we also went ahead with methylprednisolone on pulse. Apart from that, the child was in follow-up in autism clinic where ABA, occupational therapy, and sensory integration therapy was done, following which there was an improvement in the CAR score from 38 to 30. So, as this is a very rare syndrome, I would just like to introduce this in very brief. So, CAT6A syndrome is a rare neurodevelopmental disorder because of the de novo mutations which happen in the child, and multiple there has been a case report of 76 cases who are presented with microcephaly, intellectual disability, hypotonia, seizures, speech delay, strabismus, ptosis, and visual defects. Apart from it, very striking dysmorphic features has been described in CAT6A syndrome, which we can also see in our index case, that is low set ears, bulbous tip, smooth philtrum, and tented upper lip, like we can see in the other patients which we have been reported. So the take-home message from my presentation is that the etiological spectrum of the CSWS ESS is ever expanding. Genetic testing plays a crucial role, as even epileptic encephalopathy like SWAS is associated with multiple genes, as we can see in this that multiple genes have been associated with SWAS and CSW and CSWS, and we hereby report a case of CAT6A syndrome which presented to us with CSWS. Thank you.
Thank you, Dr. Diksha. Now I invite Dr. Pratik, who is her mentor, for a brief comment or a message from this presentation.
Good evening, sir. The only message I wanted to is that whenever we suspect CSWS, we treat or then we see the EG and other response. But many times we actually do not get this whole exome sequencing and this chromosomal microarray done. but we should go ahead with exome sequencing in all these cases. Usually we do exome sequencing in cases who had early onset seizures. So in this case, we had these early onset seizures. That's why we went ahead with exome sequencing. But I think in every case of ESES, at least we should, whenever there is autistic regression and other things, we should go for this whole exome sequencing and chromosomal microarray.
Thank you. Now we invite the next presenter, Dr. Ruchita, who is from Indira Gandhi Institute of Child Health, Bangalore.
You have 5 minutes, and Ruchita, you have 42 slides, so that's not possible. So you can skip the ones.
Yes, ma'am.
Okay.
Just,
Yeah. Thanks.
just tell about the case and then summarize
Yes.
it.
Yes, ma'am. Good evening, everyone. I'm presenting the case of a 9-year-old female child hailing from Bellary district, informant being the mother, which is considered to be reliable. She presented with the chief complaints of abnormal behavior of the child, noticed it since 3 years of age, noisy breathing since 1 month, and abdominal distension noticed it since 1 month. Uh, a 9-year-old female child who was noticed by the mother that child is different from the other siblings in the following ways: that she attained walking by 3 years of age but cannot walk properly yet, cannot sit at a place, constantly keep moving, cannot talk in complete sentences, does not mingle with others, prefers spending time alone, cannot read or write, need to call multiple times for her to respond. There was a sound induced startle present. I'm not able to move the slides.
Never enter. Click double on the screen.
Sorry. A child has involuntary laugh, has open mouth most of the times, needs assistance in her daily activities like cannot dress or undress by herself, cannot take bath. And there was history of noisy breathing, which was considered to be snoring, and there was history of abdominal distension, which was non-progressive and non-aggravating and relieving factors. There was no history of seizures or loss of consciousness, no history of sleep disturbances or aggressive self-injurious behaviors, no history of restricted or repetitive behavior. No previous hospital admissions were present, and she was born to third-degree consanguineous married couple, and her siblings were normal. No similar complaints in the sibling. Antenatal history was normal and natal history was normal. Nutrition and immunization history was normal. Coming to developmental history, there was a delay in attaining all the milestones like gross motor, neck holding by 6 months, rollover by 10 months, sitting without support by 2.5 years, walking by 3 years, able to climb stairs by 5 years, now cannot run. And coming to language, monosyllables by 6 months, bisyllables by 1 year, can speak 5 to 6 meaningful words, but needs repetition to understand and cannot talk in complete sentences. In social milestones, social smile by 3 months, recognized mother by 6 months, stranger anxiety by 8 months, waves bye-bye by 1 year. There was a poor social interaction and hyperactivity was present. So hence there was a global developmental delay present, disorder pragmatics was noticed, and intellectual disability was present, behavioral problems and speech issues. In general physical examination, vital signs were stable. Anthropometry wise was normal, except for head circumference was 59 centimeter, which was large head. On head to toe examination, there was coarse facial features, wide nasal bridge, muddy conjunctiva, short neck, open mouth, drooling of saliva. However, no corneal clouding or spine was normal. These are few of the images. There was right hand polydactyly, short stubby fingers were present, protruded abdomen was noticed, skin was dry and scaly, and right lower limb appeared shorter than the left one. On systemic examination in per abdomen, there was moderate hepatosplenomegaly. Liver was 5 to 6 centimeter under right costal margin and with firm to soft consistency. Spleen was around 4 centimeter under left costal margin, which was firm consistency. In central nervous system examination, about higher mental function, child was alert and oriented. However, child was hyperactive. She could understand the speech, but she was inattentive, needs repetition. There was poor eye contact with inconsistent response for the name, and word output was less. In cranial nerve examination, there was bilaterally no abnormal
abnormality was detected. And on fundus examination, there was no cherry red spot or retinal degeneration. And in 8th cranial nerve examination, sound-induced startle was present. In motor system, no significance in the bulk was noted. In tone, hypertonia in all the limbs was noted, right more than left, according to modified Ashworth score of 2. Power was normal, 4/5. Reflexes, deep tendon reflexes were brisk in lower limbs, very normal in upper limbs. And bilateral plantar flexor response was flexor. The sensory system examination was normal and there were no involuntary movements. Other systemic examinations were normal. So in summarizing the case, there was a 9-year-old female child came with autistic features started from 3 years of age with intellectual disability, with quadriparesis right more than left, with coarse facies, with polydactyly, with sound-induced startle, with hepatosplenomegaly. So hence there was a mucopolysaccharidosis phenotype, and we considered the differential diagnosis being mucopolysaccharidosis type 3, mucolipidosis type 3, and other lipids, lysosomal storage disorders like monocytosis, sialidosis, and fucosidosis. Points in favor of MPS
Dr.
type 3
Ruchika,
were...
just tell the final diagnosis and how did you achieve that diagnosis? Just tell that. Summarize.
Yes, sir. So hence, on history and examination, there was MPS phenotype was present, sir. But on investigations, CBC was normal, thyroid profile was normal, but skeletal survey was normal, which was against the MPS phenotype and most of the lysosomal storage disorder. This was the skeletal survey. Hence, we went ahead with MRI brain, which showed corpus callosal thickening, hyperintensities in the bilateral periventricular region, and cerebellar atrophy. And we went ahead with a urine for glycosaminoglycans, which was absent. So hence ruling out the mucopolysaccharidosis. This is the brain MRI images showing periventricular hyperintensities, corpus callosal thinning. Hence, instead of doing individual enzyme testing, we went ahead with exome sequencing, which showed novel frame shift deletion variant, which was likely pathogenic in the exon 8 of the AGA gene, hence diagnosing the condition aspartyl glucosaminuria. For the biochemical confirmation, we further tested for enzyme activity, which there was a deficient activity of glycosyl asparaginase is obtained in the peripheral blood leukocytes, which was consistent with the diagnosis of aspartyl glucosaminuria.
Thank you. So I will invite Dr. Vaikunt Raju sir, who is her mentor,
Yeah,
for
yeah,
message.
yeah, yeah. Good evening. So this is a rare case. Usually, initially thought of this MPS phenotype with intellectual disability with artistic feature ADHD as the MPS type 3. So after glycosaminoglycans are negative and skeletal survey negative, so you are done whole exam. It is suggests aspartyl glucosaminuria. It is a very rare condition, till now not reported from Indian subcontinent. So you should consider this condition in any child with MPS phenotype. That is the only thing unusual. Thank you.
Thank you, sir. Now I'll invite Dr. Shivaranjani from Sri Ramachandra Medical College, Chennai.
Good evening, respected faculties. I'm Dr. Shivaranjani, a second-year pediatrics postgraduate from Sri Ramachandra Medical College, here to present an interesting case of autism mimic under the guidance of Dr. Ranjit Kumar sir, who is the consultant pediatric neurologist and epileptologist of our institution. So we had a 6-year-old child who was previously developmentally normal and was brought in with complaints of language and speech regression over the past 8 months, associated with 2 episodes of vacant stare. So this child was the firstborn of non-consanguineous marriage, and he had a gradual loss of language comprehension and speech. He was not responding to commands. He had self-talk and irrelevant talk. It was associated with 2 episodes of vacant stare 1 week prior to his presentation, each episode lasting for about 1 to 2 minutes. It was associated with unresponsiveness, but there was no motor component associated. The antenatal, natal, and neonatal periods were uneventful. There were a history of seizures in the paternal grandfather, details which were unclear. There was no history of hospitalization in this child up to about 4 to 5 years of age. And according to the parents, at 4 years of age, the child was able to hop. He was able to write words. He was able to recite stories and follow 3-step commands. He was also able to perform group play, which leaves an impression of a developmentally normal child. So these are some videos before the child developed the regression. In this video, we can see that the child has good verbal as well as non-verbal communication, good gestural communication. He's performing group play with his cousin brother. He's consistently waving bye-bye throughout the video. And in the end of the video, we'll also be able to see him blowing kisses to the person who is recording the video. In general, also, he looked to be a very happy child, full of smiles. On examination, he was hemodynamically stable. General examination was normal. He had no neurocutaneous markers or no dysmorphic facies. Anthropometry revealed a large hyperpigmented macula over the left half of forehead, and he was obese, and the head circumference was normal. CNS examination revealed a limited vocabulary, irrelevant speech. He was not able to follow commands. He had self-talk, and there was no echolalia. The cranial nerves, motor system, sensory system, cerebellum, and the autonomic system were intact. So this is the video of the child when he presented to us. In this video, we can see that he was preoccupied in his own world, not showing interest in his surroundings. He was not attentive to the people around. He had some self-talk. He was meddling with his own fingers and body parts, which were all typical of autistic regression features. So this is the disease course in the child. The child had a normal development at up to 5.5 years of age, after which he encountered an autistic regression. So on evaluating this child, the MRI showed no significant abnormality and the MR spectroscopy showed a normal creatinine peak. The EEG showed a normal awake background and occasional left temporoparietal spikes in the awake state, with marked activation in the sleep state with a spike wave index of about 70%, showing abundant spike and slow waves in the bilateral temporoparietal occipital regions. The possibilities that we thought of were a primary autism spectrum disorder with epilepsy, a genetic or metabolic cause including cerebral creatinine deficiency syndrome or SSADH deficiency, etc., autoimmune causes like rare cases of anti-NMDA encephalitis, or epileptic encephalopathy like Landau-Kleffner syndrome, or maybe an unknown etiology. So Landau-Kleffner syndrome was an important consideration in this child given the fitting history and the clinical features. We did a clinical exome sequencing in this child, which showed a homozygous variant of KDM5B gene, which was a variant of uncertain significance. On summarizing the evaluation in this child, genetic testing showed a variant of uncertain significance. The serum autoimmune encephalitis workup was negative. The EEG showed high amplitude spike and slow waves in the bilateral temporoparietal occipital region, and MRI with MR spectroscopy was normal. So this child was started on anti-seizure medication sodium valproate. He was given pulse methylprednisolone therapy and was later changed to oral steroids. All this medical therapy was done in conjunction with good speech therapy and behavioral therapy. After which the child showed good improvement and the self-talk reduced, his eye contact and speech also improved. A word about EE-SWAS, that is epileptic encephalopathy with spike wave activation during sleep, and a developmental epileptic encephalopathy with spike wave activation during sleep. These entities are characterized by the onset of seizures at between 2 to 12 years of age, peaking between 4 to 5 years, with the EEG developing spike and wave activation in sleep, usually 1 to 2 years after the onset of seizures, associated with cognitive and behavioral regression or plateauing. Landau-Kleffner syndrome is a subtype of EE-SWAS, which is a rare form of epilepsy.
Just conclude.
Okay, sir. So, this child effective treatment for Landau-Kleffner syndrome is corticosteroids, and the other useful drugs identified are clobazam and sodium valproate. So this is the EEG post-therapy, which showed a marked reduction in the interictal epileptiform discharges. This is the current status of the child post-steroids. In this video, he's shown to perform some magic show. So his eye contact and social interaction had dramatically improved. He's completely seizure-free now, and the parents are happy with his progress. So I'd like to conclude by saying that autistic regression features typically occur between 1.5 to 3 years of age. So in any child who's presenting with autistic regression with or without epilepsy beyond 3 years of age, it is important to rule out organic causes. Thank you.
Thank you. Thank you. I invite Dr. Ranjit for a quick comment.
Yeah. So good evening all. So presence of epilepsy itself is a kind of a marker or a red flag should make a pediatric neurologist evaluate for underlying etiologies. So this child was typically normal until 5.5 years of age, even on repeated probing on the previous videos. So it's good to look at the past videos and analyze where the parents missing some form of history. So this child was perfectly normal until 5.5 years. and then had a slow regression which went on unnoticed for 1 year. So it's very important at every visit to pick up that subtle signs of regression. So this case is a typical case of ESWAS. Although we couldn't establish any definite etiology, the variant which came was a VUS, which is not phenotypically matching, and he responded very well to the conventional form of treatment. So any child presenting with social or language regression beyond 3 years of age should be evaluated for organic causes. That's the message.
Ranjit, did you do autoimmune workup in this child?
Yeah, so we did autoimmune workup, which was negative, including NMDR antibody.
Thank you. So I invite the next speaker, Dr. Sangeeta from Nair Hospital, Bombay.
Can you hear me? Hello?
Yes, Sangeeta, you are audible.
Good evening, everyone. I'm Dr. Sangeeta Selvam. I'm a fellow student in pediatric neurology from BYL Nair Hospital, Mumbai. My mentor is Dr. Alpana Kondekar, ma'am. Today, I'm going to talk about epilepsy and autism. It's a cause and comorbidity and association. I'm not able to click the next. Yeah. Sorry. A 16-year-old girl born by non-consanguineous marriage, second by birth order, Hindu by religion, presented with the complaints of episodes of excessive cry. These episodes lasted for 2 to 2.5 months. The child was uneventful birth history, full-term normal delivery, 2.5 kg. She had normal milestones till 3 months of age. Social smile was achieved at 1 month, recognized mother by 2 months. Later, at 6 to 8 months, child had decreased activity, loss of social smile, stopped recognizing mother, following objects. Developmental arrest happened. No motor or social language milestone was gained. The first seizure during the infancy period, the child had right focal motor seizure, 3 to 4 episodes a day. This was followed by infantile spasm, which is diagnosed as Rett syndrome and started on ACTH, 20 units per day. Frequency of spasm reduced after 7 days. After 6 weeks, spasm reduced to 10 to 15 times per day. Surprisingly, with ACTH, her stereotypical movements also decreased. The repeat EEG was done after 1 month, showed multifocal epileptiform activity with burst suppression pattern, and patient was started on vigabatrin and valparin. At 1.5 years, patient developed autistic features, no eye contact, and poor socialization. And patient had stereotypic movements, hand wriggling movements, biting the forearm, and making noise, rubbing of eyes, clapping, likes to be raw. At 1.5 to 2 years, MRI brain was done, showed hypermyelinated anterior limb of internal capsule. EEG changes suggestive of multifocal epileptiform activity with generalized burst of polyspikes, sign of modified hypsapnea. This is a EEG changes suggest.
बैठे हुए क्यों? मैं तो सबको कहा था चले जाए.
First EEG suggestive of multifocal epileptiform activity with generalized burst of polyspikes, signs of modified hypsapnea. Second EEG is also showed modified hypsapnea. Third EEG was done, showed multifocal epileptiform activity with burst suppression pattern. Developmental milestones, gross motor, rollover by 2 years, sitting with support by 2.5 years, standing with support by 3 years, walking by 3.5 to 4 years. Fine motor was delayed. Language receptive, no response to name, bisyllables 4 to 5 years. Language regressed completely after the age of 7 years. Social milestone was inconsistent eye contact, no imitation, no joint attention, no emergence of symbolic play. This is the video of the child. So it's not playing here.
It's okay. Just convey if anything in particular in the video.
The child has repetitive behavior and poor eye contact and.
Okay. Go to the next slide. Thank you.
Okay. Further clinical case, child had after that myoclonic jerks, head drops 7 to 8 episodes per day. Frequent falls and frequency increased over the period of time. By 9 to 10 years, child had head drops, tonic drop attacks, focal motor seizure. The child was on started on valparin and lamotrigine. We investigated further with urine MRST, urine for organic acid, which was negative, homocysteine was negative, MECPUT gene was done, which was negative. The child was diagnosed with refractory epilepsy and behavioral issues continued further with at 12 years, child developed GTCS with myoclonic jerks. Frequency increased 8 to 10 times a day. Multiple episodes of myoclonic jerks, increased behavioral issues, head banging, and self-mutilation behavior. By 16 years, multiple episodes a day despite of anti-epileptic drug, cried during seizure. Child attained menarche by 15 years and developed PCOD and menorrhagia. MRI was repeated, showed possible bilateral mesial temporal sclerosis with diffuse atrophy of bilateral hippocampus, significant atrophy of left-sided fornix and mammillary body, atrophy of left temporal bone, focal areas of cortical and subcortical blurring. This was the fourth EEG done, which showed frontal epileptiform activity. And this is another video. Here also the child has repetitive stereotypic behavior. Overall diagnosis is developmental regression followed by developmental arrest, age-dependent epileptic encephalopathy, autistic features, stereotypic movements, multiple seizure semiology with uncontrollable seizures. So we investigated with whole exome sequencing, which showed SIK1 gene mutation and exon 2, which is heterozygous, suggestive of early infantile epileptic encephalopathy, autosomal dominant with a variant of uncertain significance. So so we diagnosed SIK syndrome is a newly described developmental epilepsy disorder caused by de novo pathology.
Thank you. I will invite Dr. Alpna for a message from this presentation. Very nice case.
This child was following up for quite some time, and very rare epileptic encephalopathy mutation which was found, that is SIK1, which is salt-induced kinase mutation, and it is also responsible for the autistic feature if we see the complex interaction between the genetic loci where it is located. So my only message through this case that there are many clinical overlap we see in most in conditions where they come to whenever we have a complex neurological condition, the genetic testing and ruling out autism is very important. And especially we should consider that this case is not autism when we have a strong family history, strong history of consanguinity, early onset seizures, refractory seizures, any neurocutaneous markers, or any abnormal neurological findings. Thank you.
Very true. These are most probably secondary autistic features. Okay, thank you. So I invite Dr. Mohammad Anas from Rainbow Children Hospital, Hyderabad.
Good evening, everyone. So, a 2.5-year-old male child born to third-degree consanguineous parents was brought with complaints of speech delay and impaired socialization from 18 months of age in the form of poor eye contact, poor response to name calling, repetitive hand flapping, fixed interest, being obsessed with rotating objects, intermittent to walking, tantrums, and head banging. The child had initial gross motor milestones were appropriate, but walking independently at 20 months. Fine motor, pincer grasp attain was 18 months. There was delay in language as well, despite initial normal language milestones. No meaningful word as of now. No, not following simple commands. Not waving bye-bye, not indicating forward pan, no proto-declarative pointing, no joint attention, not indicating any body parts. Vision and hearing was appropriate as from the history. Child was treated as an autism spectrum disorder. He was on speech, behavioral, and OT therapy from the past 4 to 5 months, and they were taking some supplements. Parents noted to have some minimal improvement, but overall, he was still not improving. So there was a history of consanguinity, third-degree consanguinity. He was the only child, uneventful perinatal period. This was his clinical image. On general examination, head circumference is normal, no neurocutaneous markers, normal iris. CN examination showed inconsistent eye contact. He has restless, poor eye contact. We could see stereotypies in the form of hand flapping. This gastrocnemius spasticity was catched like Ashford, modified Ashford 1. He was walking independently. But what was striking in this case was the hypopigmented hair. This led us to the hypothesis that could be a metabolic, like a phenylketonuria. So we had sent TMS, and this is what we got. There was 10-fold elevation in phenylalanine levels, 1174. Cyst of phenylketonuria. For confirmation, whole exome was sent. He already had come with an MRI brain, which showed periventricular hyperintensity, more in T2 axial, more in the peritrigonal region. We got the whole exome sequencing report, which showed a defect in PAH gene, exon 9 homozygous deletion. It was a VUS, but a phenotypic match. So he was started on phenylalanine-free diet. On follow-up after 8 months, there's improvement in motor and cognitive domains. He was able to run briskly, climb up and down the stairs. His response to name calling and eye contact improved. The reduction in motor stereotypies, calling commands was better, but yet he had not achieved any meaningful speech, but receptive speech had improved. There's drop in phenylalanine levels from 1174 to 715. So a review of literature. Yes, Yelas et al. Looked at 146 patients treated for phenylketonuria. They noticed that almost 10% of all the late treated kids were severely autistic, and none of the children treated after 12 months had a normal mental health. And a paper by Sabrina et al. Showed that proportion of autism was 6% in the group of 35 kids who were diagnosed at late onset phenylketonuria. So this final remarks before concluding. Phenylalanine inhibits sodium potassium ATPase activity in synaptosomes and myelin, leads to chronic cytotoxic edema. This glutamate accelerates toxicity through the NMDA receptor, allows calcium influx into the postsynaptic neurons and resultant cell death. And also the hyperphenylalanine competes against tyrosine and tryptophan concentration in the brain, leading to a low production of dopamine and serotonin in the prefrontal cortex. So take home message, in children with autistic features, general examination should be done meticulously, not to miss hypopigmented hair, as it happened in this kid who was diagnosed as just a simple case of autism and was referred for therapies. Non-familial hypopigmented hair can claim the diagnosis like phenylketonuria and homocystinuria. Features of autism may improve with early dietary intervention. Newborn screening is still an underutilized tool and can pick up metabolic disorders early in its course. Thank you.
Thank you, Ranas. Very good case with good message. So now invite Dr. Mohan from AIIMS Delhi to present his case.
Good evening, everyone. Am I audible?
Yes.
Yeah. Good evening, everyone. Moving on to the case straight away for a want of time. So we have one 1.5-year-old girl who was born out of third-degree consanguineous marriage, who presented with the symptoms of poor eye contact, doesn't respond to her name when being called, with the lack of social interaction, along with the repetitive stereotypic behaviors in the form of hand flapping and repetition of words for the past 3 to 4 months. However, there was no history of seizures. On examination, there was no dysmorphism, there were no neurocutaneous markers, and anthropometry was within normal limits, and systemic examination was unremarkable. So this is the clinical course. We have a child with a normal birth history with no adverse perinatal events, and she had a typical development till 1 year of age, and after that, there was a regression in the language domain, along with the poor eye-to-eye contact and repetitive behaviors. Since she had a classical autistic features and DSM-5 was fulfilled, labeled child was diagnosed to have ASD and was started on a behavioral intervention. And she was on behavioral therapy, and she was slowly gaining the milestones. However, at 2.5 years of age, she had multiple episodes of seizures, along with the regression in all the domains. So now the whole history was reevaluated and reanalyzed, and now in view of global regression along with epilepsy with autistic features, possibilities considered were autism with epilepsy and gray matter neurodegenerative disorder. And the third possibility was considered was epileptic encephalopathy, which includes ESWAS and developmental epileptic encephalopathy. So we went ahead with the initial investigation, that is EEG. Here we have an epoch containing an awake EEG record, which shows occipital discharges predominant occipital discharges in the bilateral cerebral hemispheres. So this is the occipital discharges in the bilateral bilateral hemispheres, and subsequently with their awake. Subsequently, we did an activation procedure where there is a low photic stimulation was performed, which show the time-locked occipital discharges. There were abundant occipital discharges preceded by a photic stimulation. That is a low frequency photic stimulation, that is 1 Hertz. So here we have a child with EEG showing low frequency photoparoxysmal response. Concurrent workup show cerebral and cerebellar atrophy on the imaging. So finally, we have a case with a neuroregression with occipital epilepsy with low frequency photoparoxysmal response, along with diffuse cerebral as well as cerebellar atrophy. So now we revised the diagnosis and we kept possibility of neurodegenerative disorder, gray matter DBD, higher on the courts with the greater suspicion of NCL, since she had a classical EEG marker. So then we went ahead with an enzyme assay, which showed a low levels of tripeptidyl peptidase 1, proving our diagnosis of late infantile NCL. So this is the case that has been published in the reputed journal also from our division. So then we have reviewed the literature where the neurodegenerative disorder of NCL also presents with the autism as a predominant symptom and also the initial symptom. So we have a case report as well as there are case series from Costa Rica where 9 patients were retrospectively analyzed, and out of 9, 6 had a behavioral problems as their frontline clinical manifestation. So take-home messages: any new onset seizures or a neuroregression in autistic child warrants detailed evaluation to exclude other possible differentials. EEG and MRI are the major modalities as a part of diagnostic evaluation, and EEG, being an inexpensive and non-invasive technique, help to clinch the diagnosis in the index case. Thank you.
Thank you, Mohan. Prashant sir, one good message from your excellent case.
I don't have much to add. I just say sometimes even if you don't have molecular testing available to you, if you're able to use your initial investigations like EEG, MRI, and you phenotype your kid well, you can still be able to come to a diagnosis. That is all. Thank you.
Thank you. So now I invite comments from the experts, Dr. Biju sir, Veena Kalra ma'am, Shefali ma'am, about all these cases, which are like plethora of different messages. Biju sir.
Thanks, Dr. Lokesh. Fantastic cases. Now, which leaves me a little bit confused about, because we're talking about autism mimics, so conditions which may, as Dr. Shefali showed in her slides, the 2 cats, one with a tiger and a tiger with a cat. These are conditions which present like autism, but they are not autism. Is that what we mean by autism mimic? Like, for example, I think it was Dr. Raju's case. I think it was Ruchita, I think, who presented the case on the MPS phenotype.
Yes, sir. Yes, sir.
Yeah. So there are conditions where there are the recognizable dysmorphology, and the child will have autism or an autistic trait, and we would call it an autism mimic. On the other hand, we have Dr. Anis's fantastic case with the phenylalanine treatment making such a change. So, and that would be a metabolic condition where we know is associated with autism, untreated, and then were early diagnosis and treatment. So would we consider that as a condition with autism, as opposed to the epileptic encephalopathies where they have autism, but it's not a particular condition associated with autism? As in, I don't know whether those diagnoses, either the MPS or the epileptic encephalopathies, are specific specifiers for the autism. Like, for example, if we think about the genetics in autism, if we think about the MECP2 related conditions, Rett syndrome has now been moved out of the autism thing, isn't it? I think up until DSM-4, it was clubbed along with autism disorders, isn't it? Same thing with tuberous sclerosis, for example. We have children with tuberous sclerosis who have autism. It wouldn't be an autism mimic, would it? So I'm a little bit confused, and I would be very keen to hear
Dr. Tuba. Dr. Tuba.
Dr. Tuba's thing. And also, just another thing to add was there is also another single gene condition called BCKDK, which is I think the deficiency results in a deficiency of branched chain amino acids, and replacing them can completely almost cure the situation. And it's, I think, blood spot analysis is available in at least in certain centers. Same thing like phenylketonurias. So those are specific single gene conditions along with the common variants, copy number variants. But I'm a bit confused about like the autism mimic. So we're very interested to hear.
Before I give it to Dr. Tubana, Dr. Biju, I just want to remind you, you remember the ICNTN webinar last year, which I was assigned, that whether autism leads to epilepsy or epilepsy is a bidirectional thing. So it is pretty complex, not simple. So Dr. Tuba, can you, and meanwhile, Dr. Biju, think of one take-home message, which will come customary later on. Yeah, Dr. Tuba.
I feel like I could speak 15 minutes on each case presentation, but that's what happens, right? When you get a group of passionate people about autism. So the reason we need to know mimics in our field is to not miss diagnoses and to keep an open mind when the clinical presentation of the child does not make sense. Take, for example, our multiple sclerosis friends who are specialists. You know, there's a lot of conversation around MS mimics. Why? Because it's not MS. The patients present like MS, but if there's a misdiagnosis and not understanding that this is a mimic, it changes the whole diagnosis and the treatment. Right? What may be successful for MS, like in terms of rituximab, may not be as successful in its cousins in MOG and aquaporin. So the same thing happens with autism. And with autism, it's even more important because there's so many different genetic presentations. And some genetic presentations, there's different treatment modalities. Like for Rett's, now there's a medication that's kind of being tried. My patients have not shown a lot of benefits on the new medication, but some of my colleagues' patients have had improved stereotypies. So I agree with my co-expert over here. It's mimic is similar presentation, but it does not mean it is autism, right? And so we need to make that differentiation. The second thing is what combines all these different cases, right? So take the example for the phenylketonuria. When a country does case reports, right, then it becomes case series. Then it becomes a cross-sectional study, and you realize, oh, this is impacting a significant percentage of our population. And this is an easily reversible if caught early on, right? So in America, phenylketonuria is part of the newborn screening. So that's why these case reports are important. You get more and more case reports, you got to advocate to your government to put this as part of the newborn screening, because the earliest treatment, a lot of kids with phenylketonuria, when they're put on the appropriate diet, it's a huge difference. And then the last point I wanted to take home with, and I always remind our wonderful med students, is take, for example, Williams syndrome, right? People think, okay, Williams syndrome means friendly personality, so they don't have autism. Autism does not mean that you are always going to be shy and withdrawn and in a corner and not interact. It's a deficit in social interaction. That means that it's not socially appropriate for age. So when a child is hugging strangers, when a child is not understanding social boundaries, they are overly friendly, but to adaptive functioning deficit. So then that is also autism. And so that is an important thing, that it's not always the kid who doesn't approach you, who has deficits and gaze aversion. It's always, it's not always that. It can also be the kid who doesn't know how to stop staring, where it becomes uncomfortable and unsafe, or the one that goes and hugs and doesn't stop hugging for like 10 minutes till it, makes the other person uncomfortable. So that's also something to think about with autism.
Thank you so much, Dr. Hilal. Want to add something? And Dr. Tuba, you can you can think of a take-home message, because you will be you'll have to give a take-home message in the end. And thanks for staying on. It's crossed quite a lot of time, but there was a lot of interest with our passionate earlier career professionals to present. Yeah, thank you so much.
Sorry, Dr. Shafali, just to add to what Dr. Tuba explained. Sometimes, of course, like in whatever we do, the patient is in the center, isn't it? And sometimes it's important to to retain that diagnosis of autism, because like, for example, if a child presenting with autism now then turned out to be Rett, and then if we then label the child as Rett, sometimes it closes the child access to several resources which the child would otherwise have had if the autism diagnosis also had been there. So sometimes, irrespective of whatever the child may turn out to be, in actual practice, in order to try and get the maximum resource for the child, sometimes it's helpful to carry that diagnosis of autism as well.
I want to add that is why, the DSM-5, as well as which is in consonance with ICD-11, has the specifiers there. But there sometimes becomes an issue, and I want to flag that to Dr. Tuba sometimes, which one, should be put as primary and which one should be put as a specifier or a comorbidity sometimes. I understand what you're saying is from the benefits point of view, but otherwise also, when you have, it's now classically DSM-5 is accepting now that they are specifiers. Otherwise, that was not there in DSM-4TR. So would like to have your the expert views on the same.
Do you want me to go ahead now? Okay. So, MACP2, it has a cousin, CDKL5, right? I just wanted to piggyback on our prior expert. And so both have a lot of association with autism, right? And so what is more powerful? People out there don't know about the specific gene mutations, right? So you give the child the very correct and appropriate autism diagnosis. School understands now what's happening, gives more support, right? If this kid is at risk for elopement, now you've given acceptance for the parent to now be eligible for a handicap placard, right? Handicap parking can now be used. Now they have allies in autism groups, which is much larger than the tiny genetic groups, which are still powerful. Those parents are very powerful advocates, thankfully. But there's more resources that comes with the diagnosis. And so it really depends on your country, right? In most countries, now autism has gained awareness and comes with appropriate services and support for kids. I have had patients where sometimes some of the services have been rejected by insurances. So what do I teach our trainees? Everything has to be honest. But if someone is in the insurance company and sees, okay, chromosome 9 mutation, Clifton's syndrome, autism spectrum disorder, and still rejects it, okay, now you try again with those 3, but also stereotypies, poor verbal communication, because a lot of the symptoms also have their ICD codes. And so now you're like explaining 10 problems, and you're not just assuming this insurance agent who knows the autism, knows all the accompanying deficits that this child is facing. So the more problem lists you put, the more services this child has access to. So I agree with both of you. It really is a powerful tool in giving services to kids.
Sure.
So Hilal, you want to add something? Your opinion from Bangladesh?
No, madam, thank you. Already I have said from Bangladesh perspective, but our main struggle is to onboard all the multidisciplinary team for the autism management actually. This is our main struggle because the psychiatrist, psychologist, pediatric neurologist, we are struggling to onboard all of them to management of the autism spectrum disorder. This is our challenge.
Thank you. Dr. Veena Kalra, ma'am. Dr. Veena Kalra, ma'am, your final comments on the cases and overall?
Right. So I think it's very important to say that everything that we diagnose on the basis of symptoms, the diagnostic criteria as autism, is a set of children who have these symptoms. The others that we have defined in our presentations are some of the causes of these children either having primary autism or developing late onset autism after, let's say, maybe a severe epilepsy syndrome or a severe epileptic. So I think it's important to, if you take the analogy from West syndrome, one is a cryptogenic condition. The other is a symptomatic West syndrome. So I think what we describe in the cases are the symptomatic where we know the etiology and we can be put something like a symptomatic autism, whereas the others are the cryptogenic or the undefined autism. But it's important to know that autism that comes from diseased entities, let's say tuberous sclerosis, let's say even a post-meningitic sequela, all these are autistic symptoms. But when sometimes we talk of autism, we are meaning a little different pure entity that we recognize as a child who's between the age of 1 to 3 years and he undergoes a regression. So I would myself like to make a distinction between the two for even the support system that the society has to offer. Because I think the two categories behave differently. In one, we need to look for a cause, we need to identify it more clearly. In the other case, we are talking of a set of symptoms where we are not quite clear of why it happened in the large majority. And I think there are handles like, let's say, subtle dysmorphisms, hair color, phenotypes, family history, which help to make these distinctions. When you get autism with any of these distinctions, it's important to do a genetic typing, I think, in those. Whereas in the other, when you get some handle either of dysmorphism or a neurological abnormality or an odd clinical profile, which means either a very late regression or a very, very sudden regression. So these are entities where you would like to investigate further, look for a cause, look for maybe genetic, metabolic tests. But in the large majority, as we defined in the first set of the presentations, mimic is something that tells you whether you are autistic versus you're not autistic. The other thing tells you, is this autism the cause versus autism with a so far unidentified cause. And I think they are dealing with different aspects of the condition. Okay, that's what I have to say.
Thank you. Thank you, ma'am. Thank you so much for summarizing so well and making it clear in actual practice. Dr. Hassan, our dear friend from Turkey, need him to say some comments, after which then Dr. Biju and Dr. Hilal, and finally, Dr. Tuba will give the last message. Yeah. Dr. Hassan, hi.
Thank you. Hi, Dr. Shifai. Thank you very much. I really enjoyed this webinar. This is a really cross look at approachment to the autistic spectrum disorders from the pediatric neurology side and then the pediatric neuropsychiatric child psychiatry side. I really enjoyed that. Thank you very much, all the presenters, case presenters, and the panelists and experts. I really enjoyed that. Thank you very much.
Thank you. Thank you. Dr. Biju, your take-home message. Then Dr. Hilal and then Dr. Tuba.
Thanks, Dr. Shafali. I think everything has been said. It's been a fantastic session. I don't know. I suppose, I think the one point which I might want to stress here is like a child with autism is a child with autism. I don't think no two children are the same. And I would like to echo Dr. Hilal's mention about the assessment. It's very important that the assessment should be integrative, should be multidisciplinary and comprehensive, because we know that autistic children don't take change and uncertainty very well, and it can provoke huge amounts of anxiety. And it's very important that, like, right from the referral through to discharge from the autism assessment service, it has to be quite consistent as much as possible, which means like we have to improve the confidence of centers which are diagnosing autism with the other stakeholders, so that like there is no duplicated assessments. Child gets assessed in one center, then goes on to another center, gets assessed again. It's not fair at all on the child and the family. So that integrated, comprehensive, multidisciplinary autism assessment is very important. And hence there is an acute need for training more and more people in terms of assessment, and like we mentioned, the complexities associated with learning disabilities, etc. So that's probably my take home point for today. It's very important, like we need to how we approach autism assessment. And then I suppose leading from that, like, autism is indeed a clinical diagnosis, irrespective of all the ADI and the ADOS that we all use. Those are all just tools. Ultimately, it's a clinical diagnosis, which then begs the question, who should be ideally be making a diagnosis of autism? Should it be the developmental pediatrician, or should it be the pediatrician, or should it be the neurologist who should do that? Thank you.
Thank you. We've already overshot by 64 minutes, I think. Dr. Hilal, your one-liner message, and Dr. Tuba final.
Thank you, madam. My one-line message is like Dr. Biju, that we need the multidisciplinary assessment and management, and also I need sometimes the cross history taking from the informant, because one parent said some misinformation, one parent said the just opposite information regarding the child. So always try to make the cross interview of the informant. Thank you, madam.
Thank you. Dr. Tuba.
Well, it's great to connect and hear everyone's thoughts and experiences. And I think at the end of the day, it's really important to remember we're not just our patients' physicians, we are our patients' advocates. And if we can advocate for them in their communities, in their schools, and even as simple as writing a letter for them to have access to handicap parking for a child that elopes, can really make a difference. So definitely continue those advocate hats that you have. And thank you for having me.
Thank you so much. And I think very rightly what you had said, that you have to look at the child holistically, even if it's you're seeing it is as a whole case. We have to be seen holistically, and certain small cues can give you the leads. And yes, humanism is very, very important, and everybody needs to be treated with dignity, and that is something very, very important. And thank you so much. Lokesh, you want to add something or before I close?
No, just one thing that we see in India, the commonest autism mimic is hypoglycemic brain injury.
And we are actually trying to work on the general movements and all on seeing. Anyway, that can come later. Just wanted to tell you that thank you so much for the amazing speakers and amazing experts and amazing presenters from India and Turkey, and the attendees who are there. And want to tell you that, yeah, right now we have 70 on when it is 65, 66 minutes beyond schedule. We want to try to limit to 1.5 hours. And I think next time we have two amazing professionals, real stalwarts from the other side of America next week. So please do come in next week. And so we'll have two amazing experts on autism. Thank you so much. Thank you very much, everyone. Thank you. Have a great day and good evening and good night. Thanks. Bye-bye.